Welcome to the deep dive. Today we're tackling a real cornerstone of vascular practice, cerebrovascular disease.
That's right.
Yeah.
Specifically, Section 13 from the latest Rutherford's vascular surgery and endovascular therapy.
And this isn't a quick read, is it? It covers chapters 88 all the way through 102. That's what, 15 chapters?
15 chapters, yeah. It's comprehensive.
Yeah.
So our goal today really is to synthesize all of that down.
Kind of distill it.
Exactly. Distill it into a focused, practical guide. Think of it like an instruction manual for vascular surgeons dealing with these diseases day in, day out.
Okay, an instruction manual based on Rutherford Section 13. I like that.
Yeah, it's about giving you the shortcut to the core knowledge, cutting through some of the density to get to the essential strategies, the critical decision points, and looking at how things are evolving in the field.
So what kind of ground are we covering? It sounds broad.
It is broad, but we'll hit the key areas. We'll look at the basics, epidemiology, pathophysiology, who gets this stuff and why. Then the real nuts and bolts of management.
Medical management. Surgical.
Both. Optimal medical therapy, open surgery like CEA, endovascular techniques like stenting, TCAR, even acute stroke interventions. We'll touch on specific conditions too. Carotid stenosis, obviously, aneurysms, vertebral disease, stroke.
Okay, so it's a pretty wide sweep. Let's break down that structure a bit more. How are we going to tackle these 15 chapters?
Logically, I think. We'll start with Chapter 88, the epidemiology. Got to understand the scale of the problem first.
Makes sense.
Then we'll touch on Chapter 90, cognitive dysfunction, an important link. Chapter 92 is critical. Decision-making and optimal medical therapy. That's where a lot of the core strategy lies.
Right. OIT.
They'll get surgical. Chapter 93 on carotid endarterectomy, the technique, the results. Chapter 94 on carotid artery stenting, which is always evolving.
Yeah.
Chapter 95 covers endovascular therapy for acute ischemic stroke, hugely important now. Then we'll look at some less common things. Chapter 97 on carotid aneurysms, Chapter 99 on uncommon cerebrovascular disorders, and we'll round it off with Chapter 101, surgical treatment of brachiocephalic artery disease. So it's a journey through the section, hitting the highlights relevant for practice.
Got it. So for the vascular surgeon tuning in, or maybe someone else really interested in this field, why stick with us for this deep dive? What's the key takeaway?
Well, fundamentally, cerebrovascular disease is just a massive issue. Leading cause of death and disability worldwide. This isn't about, just reciting textbook facts.
Right.
It's about pulling out the actionable intelligence from Rutherford's. What are the established best practices? Where's the debate? Where are things heading?
So giving them a clearer map to navigate these complex cases.
Exactly. A more efficient understanding, helping you stay current in a really dynamic specialty.
All right. Sounds valuable. Let's jump in then. Chapter 88, Epidemiology of Cerebrovascular Disease. Laying the foundation for our instruction manual.
Absolutely. And Chapter 88 really drives home the point. Stroke is a major, major killer and cause of long-term disability globally.
And it's strongly age-related.
Definitely. Prevalence just climbs dramatically with age. Figure 88.1 in the text shows this very clearly.
Okay.
Now, an interesting point the chapter makes is about asymptomatic internal carotid artery stenosis, ICA stenosis. There was hope that better medical therapy, like widespread statin use, was really going to dent the stroke incidence from this.
And has it?
It likely has had an impact, yes. But ICA stenosis still contributes significantly. One estimate mentioned is around 41,000 strokes annually in the U.S. alone, just from previously asymptomatic extracranial ICA stenosis.
Wow. Okay. So still a major factor. Still a major factor. Although it's worth noting, the Global Burden of Disease study offers a slightly different perspective on some trends. So the picture is, complex and still evolving.
Yeah.
You can't get complacent.
Right. So what are those key risk factors that, as surgeons, we really need to have front of mind?
Several stand out. Family history: having a first-degree relative with stroke, TIA, or MI. That increases risk by maybe 1.4 to 3.3 times.
Very. Atrial fibrillation is another big one, boosting the risk of cardioembolic stroke by 3 to 5 times.
Huge.
And smoking. Still a major player. Doubles or even quadruples the risk. The good news, though, is that quitting smoking helps a lot across different patient groups. It really reinforces why hitting those modifiable risk factors is so crucial in our overall strategy.
Absolutely. So those are the risks leading to stroke. What about after a stroke? What are the mortality stats?
They're pretty sobering, honestly. The ERIC study, atherosclerosis risk in communities, showed over 10% all-cause mortality within just 30 days after a stroke.
10% in 30 days.
Yeah, and it climbed steeply over time, nearly 60% by 24 years post-stroke. Another report from the CDC looking at Medicare patients showed 30-day mortality varies with age from about 9% in the 65-74 group up to 23% for those over 85.
Wow.
Figure 88.6 in Rutherford shows the one-year probability of death after a first stroke, too. It really underscores the severity and, well, the urgency of prevention and effective treatment.
Okay, then there's the TIA, the transient ischemic attack. How should we, as surgeons, think about TIAs?
You know, patients often hear mini stroke and maybe think it's not serious because the symptoms go away, usually within minutes, almost always within 24 hours.
But it is serious.
Absolutely. Rutherford calls it a critical warning sign. About 30% of TIA patients go on to have a full stroke within 5 years.
30%.
Yeah. And even though it's a clinical diagnosis based on symptom resolution, you have to remember that actual brain damage, infarction, can occur. One study mentioned in the chapter found infarction on brain CT in nearly a quarter, 24% of patients who presented with a clinical TIA but had no prior stroke history.
So even if symptoms resolve, there might be underlying damage. It's not benign.
Not at all. It needs thorough investigation and really aggressive risk factor management.
Are there specific signs or patient factors after a TIA that should make us particularly concerned?
Well, the classic symptom pointing towards a carotid source is amaurosis fugax,
Yeah.
that temporary painless vision loss in one eye,
Yeah.
like a shade coming down. Interestingly, TIAs from carotid emboli often present with these focal deficits, while TIAs from cardioembolic sources can be more varied.
Okay. What about predictors of stroke after a TIA?
Key independent predictors highlighted are age over 60, having diabetes, focal symptoms during the TIA itself, and if the TIA lasted longer than about 10 minutes.
Longer duration matters.
It does. And the short-term risk is really quite high, something like 3 to 10% risk of stroke within just 2 days, and 9 to 17% risk within 90 days. It just hammers home the need for prompt evaluation and action.
Okay, which brings us neatly to the underlying cause in many cases. Extracranial carotid artery atherosclerosis. How does that plaque actually cause these events?
Rutherford is clear on this. The main mechanism for TIA or stroke from carotid disease is embolization. Bits of plaque breaking off and traveling downstream to block smaller brain vessels.
So it's less about low flow, more about debris.
Much more about debris. Hypoperfusion, or low flow, is pretty rare as the primary cause because the brain usually has good collateral circulation. Hollenhorst's early work really highlighted this embolic mechanism.
And the degree of stenosis, how important is that?
It's critical, especially in symptomatic patients. The severity of the stenosis is a key predictor of their stroke risk, and it's the most important factor in deciding who benefits from intervention, whether it's surgery or stenting.
How common is this stenosis in the general population? Is this something we see everywhere?
It's definitely common, and prevalence goes up sharply with age and also with higher cholesterol, blood pressure, and smoking history. The Tromso study and others show this.
Right.
Now, screening asymptomatic people is still debated,
Yeah.
But one meta-analysis estimated that about 21% of people aged 30 to 79 have some carotid plaque, and maybe 1.5% have significant stenosis. That's millions of people.
Millions.
Yeah. And one screening program actually found that undiagnosed significant ICA stenosis was picked up more often as a potential treatable cause of stroke than newly found high blood pressure or AFib.
That's quite striking. Are there specific risk factors beyond just general atherosclerosis risk that point towards developing carotid stenosis?
Yes, several are strongly associated. Advanced age, smoking history, definitely PKD, peripheral artery disease, also hypertension, coronary artery disease, CAD, diabetes, high cholesterol, and having an abdominal aortic aneurysm, prevalence.
A lot of overlap with general vascular risk.
Huge overlap. There's also some suggestion that exercise and diets high in fruits, vegetables, and nuts might be protective.
Interesting. Any differences by sex or race?
Yeah, prevalence does vary. Native Americans seem to have the highest rates across age groups and sexes. It's also important for us to remember as surgeons that while African Americans have higher stroke rates overall, it might be driven more by small vessel disease and hypertension, not necessarily just carotid plaque burden itself.
That's a really important clinical nuance. So when we do find asymptomatic carotid stenosis, what guides the decision on intervention? It's not just the percentage, right?
Right. Rutherford emphasizes that for asymptomatic patients, intervention CEA or CAS should really be reserved for those estimated to be at a high lifetime risk of stroke on that same side.
Okay, so how do you estimate that?
It's not just about the percentage stenosis. You need to look at other factors. Is the stenosis progressing over time on imaging? Are there high-risk features of the plaque itself on ultrasound or CT-MRA?
What does the evidence say about the baseline risk?
Landmark trials like ACS, the NASAT asymptomatic arm, and ACST consistently showed about a 2% annual stroke risk with high-grade asymptomatic stenosis, even with increasing statin use in the later ACST years.
So 2% per year, roughly.
Roughly. And the ReCH registry also found that even on statins, significant asymptomatic stenosis carried an increased stroke risk. Plus, studies show that if the stenosis progresses, the risk of ipsilateral stroke goes up.
Okay. And what about the other main circulation territory, vertebrovascular insufficiency, VBI? What's the key message there for surgeons?
VBI is about inadequate flow to the back of the brain, brainstem, cerebellum, occipital lobes. It can be caused by emboli, thrombosis, or just low-flow hemodynamic issues.
Like subclavian steel.
Exactly. Subclavian steal syndrome is the classic example of VBI from low flow. A blockage in the subclavian artery before the vertebral artery takes off can cause blood to flow backward down the vertebral to supply the arm, especially with exercise.
Stealing blood from the brain.
Precisely, leading to symptoms like dizziness, vertigo, double vision, things related to that posterior circulation, often triggered by using the arm.
Okay, let's move to chapter 90, cognitive dysfunction. This feels like an area that's getting more attention.
It definitely is. Rutherford discusses this growing link between asymptomatic carotid stenosis and cognitive impairment,
Right.
even without a definite stroke.
Just the presence of stenosis impacting thinking.
That's the idea. And there's also research, though maybe less definitive, suggesting that procedures like ECIC bypass, that's extracranial intracranial bypass for severe carotid occlusion, might actually improve cognitive function in some select patients, potentially by improving blood flow or reactivity.
Interesting. But the outline also mentioned cognitive changes after carotid interventions themselves, CEA or CAS.
Yes, and that's a really crucial point for patient counseling. Rutherford acknowledges this can happen. Both CEA and CAS have been associated with cognitive changes in some individuals post-procedure.
Why would that happen?
The exact reasons aren't fully clear. It could be related to tiny microemboli during the procedure, maybe changes in cerebral blood flow patterns, or even the body's inflammatory response to the intervention. It highlights this complex link between our vascular procedures and brain function.
Definitely something to be aware of and discuss. Okay, let's dive into chapter 92. This sounds like a core chapter, decision-making and optimal medical therapy, OMT.
Absolutely. This is where Rutherford really lays out the strategic approach for managing carotid territory TIA or stroke. It boils down to 3 pillars.
Which are?
1,
Yeah.
tackling those modifiable risk factors we talked about. 2, really optimizing medical therapy, OMT. And 3, carefully considering revascularization, CEA or CAS.
We covered risk factors. Let's focus on OMT. What does that entail today? Has it changed much?
OMT is aggressive management. Lifestyle changes, smoking cessation, weight, exercise, alcohol moderation are foundational. But the pharmacology is key.
Antiplatelets.
Antiplatelets are central. Aspirin is usually the baseline. But a big development highlighted in Rutherford's is the increasing evidence for early dual antiplatelet therapy, DAPT, usually aspirin plus clopidogrel,
When would you use DAPT?
particularly after a recent TIA or minor stroke. Studies, including data from the Vascular Study Group, suggest it can reduce recurrent events and maybe even embolization before a planned CEA, without significantly bumping up major bleeding risk.
So, for bridging to surgery or in certain high-risk scenarios.
Exactly. Maybe in low-grade stenosis with no other cause found, or moderate to severe stenosis after a recent event where you're not intervening immediately, or if urgent intervention is planned. The chapter gives specifics on loading and maintenance doses and mentions alternatives like aspirin plus dipyridamole too.
That's a significant shift towards earlier, more aggressive antiplatelet use. What else is crucial for OMT?
Aggressive lipid lowering, high-intensity statins are essential, pretty much regardless of baseline cholesterol for both primary and secondary prevention.
Statins for everyone with significant carotid disease.
Generally, yes. Plus, tight blood pressure control hitting those guideline targets. And for diabetics, strict glycemic control is vital.
Okay, so that's OMT. When do we start thinking about surgery CEA, specifically for patients who've had symptoms?
The decision really hinges on the degree of stenosis. The CETC meta-analysis carotid endarterectomy trialist collaboration is the key data source here.
What did it show?
It clearly showed significant benefit from CEA for patients with symptomatic moderate stenosis, that's 50–69%, and high-grade stenosis, 70–99%. The biggest benefit was in that 70–99% group.
And less benefit below 50%.
Right. No benefit seen for less than 30% stenosis, or for those with a near occlusion, the so-called string sign. So accurate grading of the stenosis is absolutely fundamental for deciding who gets surgery.
Are there other factors beyond just the percentage that affect the benefit from CEA in symptomatic patients?
Yes, definitely. Sex seems to play a role. The CETC data suggested men got a slightly greater absolute benefit from CEA in that 50–99% range compared to women.
Interesting. Why might that be?
It's not entirely clear. Also, women might lose the benefit of CEA faster if surgery is delayed after symptoms start.
Timing matters, especially for women.
Potentially, yes. The type of presenting symptom also influences the outcome. The absolute risk reduction is highest if the patient presented with a stroke, then TIA, then retinal symptoms like amaurosis fugax.
Wow.
And NASCET found CEA was beneficial even if the presentation was a lacunar stroke, which we often associate with small vessel disease. Also, having tandem intracranial disease doesn't automatically rule out carotid intervention in the right symptomatic patient.
What about the long haul? After the initial recovery from CEA or CAS, how do they compare in preventing future strokes?
That's where the Carotid Stenting Trialists collaboration, the CSTC meta-analysis, comes in. It looked at late outcomes beyond that initial 30-day perioperative window.
Yeah.
And it found no significant difference in the long-term rates of ipsilateral stroke between CEA and CAS, looking out to 5 and even 9 years. The annual stroke rates after that initial period were very low for both.
So both seem durable once you get past the initial risks.
That's what the data suggests. Table 92.4 in the chapter breaks down the absolute risk reduction of late stroke with CEA, factoring in those perioperative events based on stenosis severity. It's reassuring about long-term protection.
Okay, switching back to asymptomatic carotid stenosis, ACS. What's the role of antiplatelets there? Is it as clear?
It's less clear-cut than in symptomatic disease. One study didn't find a difference with aspirin versus placebo for composite vascular risk, but observational data from the ACS study suggested antiplatelet therapy did reduce TIA-stroke CV death compared to no treatment. And pre-existing aspirin use seemed linked to less severe strokes if they did occur, at least for large artery atherosclerosis types.
What about DIPT in asymptomatic patients, aspirin plus clopidogrel?
The Charisma trial looked at this and didn't show an additional benefit over aspirin alone, specifically in the ACS subgroup. So the evidence for DIPT in stable asymptomatic patients isn't really there.
So for asymptomatic patients, medical therapy is important, but maybe less aggressive antiplatelet strategy needed compared to symptomatic. What pushes us towards intervention in ACS then?
That's where the concept of high-risk features, or HRFs, comes in, as discussed in Chapter 92. These are factors beyond just the stenosis percentage.
Like what?
Things like impaired cerebrovascular, reserve the brain's ability to increase blood flow when needed, or detecting microembolic signals, MES, on transcranial Doppler, or specific plaque characteristics on imaging, suggesting instability.
And if these HRFs are present,
their presence significantly bumps up the risk of future ipsilateral stroke, or TIA, and late stroke. This might tip the balance towards considering intervention in an otherwise asymptomatic patient, if they're a good candidate otherwise.
how does the actual degree of stenosis play into risk in asymptomatic patients? Is higher stenosis always higher risk?
You'd think so, but it's actually not that straightforward. Big trials like ACS and ACST didn't find a clear, strong link between increasing stenosis severity above a certain threshold and increasing stroke risk in asymptomatic patients.
Really? That's counterintuitive.
It is a bit. The SMART study also found pretty low annual stroke rates across the 50–99% stenosis range. Data from the ACSRS study was a bit more mixed, depending on how stenosis was measured. It suggests that while stenosis matters, it's not the only factor driving risk in ACS.
What about other clinical clues, like having had symptoms on the other side?
Yes, that seems to matter. Having a history of contralateral TIA, or stroke, is associated with a higher annual risk of stroke on the asymptomatic side. Both ACST and ACSRS data support this.
And stenosis progression, if it gets worse over time.
That also increases risk. Documented progression on imaging roughly doubles the annual ipsilateral stroke risk. But importantly, most strokes in ACS patients still happen without documented prior progression.
Okay, so it's a complex risk assessment. Given all this, what do current European guidelines say about intervening on high-grade asymptomatic stenosis?
The 2017 ESV-SCSC guidelines suggest that for asymptomatic patients with 60–99% stenosis, or at average surgical risk, CEA may be considered if there's at least one clinical or imaging feature linked to increased late stroke risk.
But with caveats.
Big caveats. The center's documented perioperative stroke death rate for CEA must be low, less than 3%. And the patient needs a reasonable life expectancy, generally greater than 5 years. The guidelines list specific features they consider high risk.
And finally, for Chapter 92, how does CEA stack up against CIS specifically in these asymptomatic patients?
Meta-analyses of the randomized trials show a similar pattern to symptomatic disease. Transfemoral CA, TFCAS, is associated with a higher 30-day risk of stroke and the combined endpoint of death or stroke compared to CEA.
So higher upfront risk with TFCAS in asymptomatic patients too.
That's what the trial data indicates. It's a key consideration when discussing options. The chapter wraps up with a useful algorithm summarizing management for symptomatic stenosis based on degree and other factors.
Okay, let's move into the operating room, conceptually at least. Chapter 93, carotid endarterectomy technique and results, getting into the surgical details.
Right. And building on the medical therapy discussion, antiplatelets are crucial perioperatively for CEA too. Meta-analyses consistently show they reduce stroke risk.
What about continuing clopidogrel through surgery?
Rutherford notes that clopidogrel might decrease perioperative emboli without necessarily increasing bleeding risk significantly during CEA. Many surgeons, including the chapter author, often continue it if the patient is already on it for good reason. Aspirin is typically continued as well.
The chapter mentions aversion endarterectomy. Can you walk us through that technique?
Sure. Everton CEA is a variation on the standard approach. Instead of a long cut in the artery, the internal carotid is transected or nearly transected at the bifurcation. This lets the surgeon literally avert or turn inside out the beginning of the ICA to peel the plaque out.
Advantages, disadvantages.
Potential advantage is a very thorough plaque removal. A key consideration, though, is that the endpoint might be less visually clear than with the standard arteriotomy. So completion studies like intraoperative ultrasound or angiography become even more important to make sure the plaque is fully removed and there are no flaps or issues.
Exposure is always key in neck surgery. Any tips from Rutherford's for getting good distal ICA exposure when it's tricky?
Nasotracheal intubation can help lets the jaw close fully, improving access high up. If you need even more exposure distally, sometimes you have to divide the posterior belly of the digastric muscle.
But that carries risks.
Absolutely. You have to be extremely careful and know your anatomy precisely to avoid injuring nearby nerves. Hypoglossal, spinal accessory, glossopharyngeal are all right there.
The shunting debate during CEA routine versus selective, what's the current thinking according to Rutherford's?
It's still debated, honestly. Routine shunting means putting in a temporary bypass tube to maintain flow while the carotid is clamped. Selective shunting means you assess flow first, maybe with stump pressure or EEG monitoring, and only shunt if there are signs of ischemia during a test clamp.
Pros and cons.
Selective shunting avoids routine shunt placement, but carries a small risk from the test clamp itself, or maybe delayed flow restoration if a shunt is needed. Routine shunting gets flow back faster, but has its own small risks, like intimal injury or air emboli during insertion. The best approach often depends on the patient, surgeon experience, and what monitoring you have available.
Patch closure after CEA is common. Preferred materials? Any technical pearls?
Rutherford's generally favors using a vein patch, usually from the greater saphenous vein, GSV, over synthetic patches like Dacron.
Why vein?
Lower reported risk of late pseudoaneurysm formation. But you need to make sure the vein piece is big enough, ideally over 3.5 millimeter diameter when distended to avoid rupture. This can be more of an issue in women who tend to have smaller veins. Archie's data suggests matching patch size to bulb diameter helps prevent rupture.
Okay. Let's talk about the complication we all dread. Perioperative stroke after CEA. What are the causes and how do we manage it?
Rutherford breaks it down. Causes include thrombosis or embolism from the surgical site, ischemia during clamping, or, less often, intracerebral hemorrhage.
And technical issues are often implicated.
Very often, things like intimal flaps, residual plaque, retained thrombus at the endarterectomy site are common culprits for early thrombosis. This just highlights how crucial meticulous technique and completion imaging are.
So if a stroke happens post-op, what's the immediate plan?
Early recognition and immediate action are key for recovery. If the patient wakes up with a new deficit after GA, first step is check ICA flow with Doppler. If flow is present, you might need more imaging like duplex or angio to look for distal embolus.
And if there's no flow?
Then it's usually back to the OR immediately to re-explore the endarterectomy site. Find the thrombosis, fix the technical problem. The chapter details managing acute thrombosis, gentle thromboembolectomy, careful use of balloon catheters, fixing flaps, and being cautious if you need to reinsert a shunt.
What do the big trials tell us about the actual results of CEA these days? Stroke death rates.
Trials like CREST and ICST provide benchmark data. In experienced hands, 30-day stroke and death rates are typically in the 3–5% range for symptomatic patients.
And for asymptomatic disease.
The risk is lower, and medical therapy is improving things. But ACS clearly show that for patients with 60% asymptomatic stenosis, CEA plus OMT beat OMT alone, significantly reducing stroke risk over 5 years.
Cranial nerve injuries are another known risk. How common are they, and are they usually permanent?
Rutherford says they're the most common neurologic complication, maybe 5–20% incidence, though many are subtle. Prospective studies find higher rates than just looking back at charts.
But mostly temporary.
Thankfully, yes. The vast majority are transient, resolving in weeks or months. Permanent injury is rare, less than 1% in some big series like ECST. And CREST found that even when they occurred, they didn't really impact quality of life at 1 year.
Which nerves are most commonly involved?
Hypoglossal nerve, causing tongue issues. Mandibular branch of the facial nerve, causing lip weakness. Vagus or recurrent laryngeal, leading to hoarseness. Have to be careful identifying the vagus and watch for non-recurrent nerves. Spinal accessory, causing shoulder problems, and sensory nerves like greater auricular and transverse cervical, causing numbness around the ear, jaw, and neck that's very common but usually temporary. Careful technique is paramount.
What about managing blood pressure right after CEA?
Critical. Close monitoring, often with an arterial line. If hypotensive, fluids first, then maybe phenylephrine carefully, keeping systolic BP near their baseline. If hypertensive, strict control is crucial too. Both extremes can be bad.
And hypoperfusion syndrome, what is that?
It's a rare but serious thing. After fixing a severe stenosis, blood flow to that part of the brain can suddenly increase dramatically, overwhelming its ability to regulate. Often happens if the other side also has severe disease.
What are the signs? How do you treat it?
Severe headache, brain edema, sometimes even intracerebral hemorrhage. Hypertension is a big risk factor. Treatment is mainly meticulous blood pressure control. Risk might be higher if you do the second side CEA soon after the first.
What about patients with both significant carotid and coronary disease? How do you sequence things?
It's tricky. Options include doing CEA and CABG at the same time, or staging them, maybe doing CAS first, then CABG. The data comparing these strategies is mixed.
No clear winner.
Not definitively. Some studies suggest higher risks with combined or staged CE-Wendy-FAG versus staged CAS-CABG for certain outcomes. Others show similar risks. It really needs to be individualized based on the patient, the severity of disease in both beds, and local expertise.
Rutherford's also mentions specific groups, advanced age, women, race. Any quick takeaways there?
Just that these factors can influence disease patterns and outcomes. The chapter also touches on symptomatic low-grade stenosis with intraplaque hemorrhage as potentially higher risk, carotid webs causing stroke, limb-shaking TIAs, external carotid endarterectomy, radiation-induced disease.
Lots of nuances.
And finally, the volume-outcome relationship. Higher hospital and surgeon volumes for CEA generally correlate with lower stroke death rates. There seems to be a threshold, maybe around 79 cases a year, suggested by some studies, though hospital infrastructure and high-volume centers might be key too.
Okay, let's switch gears to the other main revascularization option, Chapter 94, Carotid Artery Stenting, CAS.
Right, CAS. Initial excitement was maybe tempered a bit by early trials, showing higher perioperative stroke rates than CEA, sometimes 6–9%.
What do the major trials comparing them show overall? Table 94.1 summarizes these?
Yes. Sapphire, for instance, looked at high-risk surgical patients and found TFCA non-inferior to CEA at 1 year for a composite endpoint. But there were questions about how generalizable that was and the medical therapy used back then.
And then there's TCR, transcarotid artery revascularization. How does that fit in? It's newer.
TCR is different. It uses direct surgical access to the common carotid in the neck, but then places the stent under flow reversal neuroprotection.
Flow reversal.
Yeah, temporarily reversing flow in the carotid system to catch any debris released during stenting. The Roadster registry showed really promising low stroke rates, around 1.4%, and good 1-year data. It's emerged as a strong option, especially for patients considered high risk for CEA.
What do the current guidelines like ACS say about CS use, recognizing they might predate widespread TCR?
The 2011 guidelines suggested TFCAS could be an alternative to CEA in symptomatic patients under 70 if procedural risk is low, 6%. For asymptomatic high-risk patients with significant stenosis and high-risk imaging features, CAS might be considered if risk is very low, 3%, and life expectancy is good, 5 years. They list specific high-risk criteria favoring CAS in asymptomatic cases like severe heart failure, low EF, unstable angina, contralateral occlusion.
Are there situations where TFCAS is relatively contraindicated, where TCI might have an edge?
Yes. Things that make TFCS tougher include older age, heavily calcified lesions, very tortuous vessels, near occlusions, difficult aortic arch anatomy, or inability to use an embolic protection device, EPD.
And TCR overcomes some of these.
Potentially, yes. The direct access avoids navigating a tricky arch, and the flow reversal provides neuroprotection without needing to cross the lesion with a wire first to place a distal filter EPD, which is standard now for TFCAS.
What about meds around CAS procedures? Heparin, antiplatelets, any TCR specifics?
Heparin is standard intraprocedurally for both. For TCR, some studies suggest protamine reversal after might reduce bleeding without increasing clot risk. Anticholinergics might be used pre-TCR. Interestingly, for TCR, they often prefer mild hypertension during flow reversal, using pressors like phenylephrine to maintain perfusion.
Okay.
DAPT aspirin and clopidogrel is crucial before and after both TFCAS and TCR. Loading doses are also used, especially if urgent. Statins are continued throughout. Intolerance to antiplatelets is generally a contraindication to stenting.
What are the potential complications specific to CAS?
Technical issues like acute stent thrombosis, stent kinking, or carotid dissection can happen. If dissection occurs, keeping wire access in the true lumen is vital. Neurologic complications are the main concern. Embolic stroke primarily, but also hemorrhage or hyperperfusion syndrome.
Similar to post-CEA hyperperfusion.
Similar concept, needs careful BP control. Subclinical cognitive changes are also reported. Then there are cardiovascular events, access site issues, rare stent fracture, and restenosis later on, which need surveillance.
Any general tips from Rutherford's for performing CAS?
Pre-op beta blocker use might lower risk. Getting a CTA beforehand for complex anatomy is often helpful. Frequent awake neurochecks during the procedure are key. Stable sheath access is paramount again. TCR might help if the arch is difficult.
All right, let's move to Chapter 95, Endovascular Therapy for Acute Ischemic Stroke, a game changer in recent years.
Absolutely. Mechanical thrombectomy has revolutionized acute stroke care for large vessel occlusions, LVOs. This chapter covers the techniques and, critically, the indications.
So who gets thrombectomy? What are the main criteria?
It's based on stroke severity, usually NIH stroke scale score. Time since symptom onset is critical, although that window has expanded, and initial brain imaging, particularly the ASPECT score on non-contrast CT.
Aspects. Can you explain that?
ASPECT's Alberta Stroke Program Early CT score. It's a 10-point score looking at early ischemic changes in the MCA territory on the initial CT. A perfect score is 10. You subtract points for areas showing early damage.
So lower score means more damage.
Exactly. Generally, thrombectomy is indicated for aspects of 6 or higher, meaning a good chunk of brain is still potentially salvageable. Those some trials, like Tesla, explored potential benefit even with lower scores in select cases. Relying on reported time of onset can be tricky, hence the importance of imaging.
And the NIH stroke scale, what does that measure?
It's a standardized neurological exam scoring different functions: consciousness, language, neglect, vision, motor strength, coordination, sensation, speech. Higher score means more severe deficit. A score of 6 or more usually indicates moderate to severe stroke, often triggering a thrombectomy evaluation if an LVO is suspected or confirmed. Simpler scales like LAMS are used sometimes in the field.
The field was transformed by several big trials. Can you summarize the key ones?
Yeah, a wave of trials starting around 2015 proved thrombectomy plus medical therapy was far superior to medical therapy alone for LVO stroke. Mr. Clean, Escape, Revascat, Swift Prime, Extend DIA, they all showed much better functional independence rates at 90 days with thrombectomy.
And then came trials extending the time window.
Right. Dawn and Diffuse 3 used advanced imaging like perfusion scans or DWI MRI to identify patients with salvageable brain tissue who could benefit even 6 to 24 hours after onset. That was huge. And ASTER compared different techniques, aspiration versus stent retrievers, finding both were effective.
So rapid identification and transfer to a center that can do thrombectomy is key.
Absolutely crucial. That leads into stroke systems of care. You need coordinated networks, primary stroke centers identifying patients, and then comprehensive stroke centers, CSCs, or thrombectomy-capable stroke centers, DSCs, that have the neurointerventional teams, imaging, and infrastructure available 247 to actually do the procedure. Certification requirements are strict. The chapter includes a helpful algorithm summarizing triage based on time, TPA eligibility, imaging, etc.
Okay, shifting gears slightly to chapter 97, carotid artery aneurysms. Less common, but important.
Right. Extracranial carotid artery aneurysms, ECAAs, not common like atherosclerosis, but risky due to potential for throwing clots, rupturing, or compressing nerves.
What causes them?
Various things. Degenerative changes like atherosclerosis, trauma blunt injury causing pseudoaneurysms or penetrating trauma, can happen after CEA2, again, usually pseudoaneurysms, arterial dysplasias like FMD, and infection mycotic aneurysms.
How do they typically present? What should make you suspicious?
Often, a painless pulsating mass in the neck is the main finding, but location matters. ICA aneurysms might bulge into the throat, may be seen in the tonsillar fossa, without much external neck swelling. CCA aneurysms tend to bulge outwards more.
Any red flags?
Tenderness, redness, fever over the mass strongly suggest infection of mycotic aneurysm. Neurologically, distal ICA aneurysms near the skull base are more likely to compress cranial nerves, causing Horner syndrome, hoarseness, facial pain, or they can present with TIA stroke from emboli or rarely rupture.
How are they diagnosed and classified?
Usually imaging duplex ultrasound, CTA, or MRA shows the size, location, thrombus. Rutherford mentions the Attica classification based on location, type I high ICA, type 2 long ICA, type 3 bifurcation proximal ICA, type 5 ECCA, and ICA, type V isolated CCA. Helps plan treatment.
What are the treatment options, open versus endo?
Both are options. Open surgery usually means resecting the aneurysm and reconstructing the artery, often with a graft, vein, or synthetic. Needs cerebral protection like CEA. Distal exposure can be challenging. Endovascular options include covering the aneurysm opening with a stent graft or filling the aneurysm sac with coils, sometimes using a stent to hold the coils in, trans-stent coiling. Choice depends on aneurysm anatomy, patient fitness, symptoms, and local expertise.
When do you decide to treat versus watch? And what are the outcomes?
Generally, intervention is recommended if it's enlarging, symptomatic, bigger than about 2 centimeters, or suspected to be infected. Small, asymptomatic ones in frail patients might be watched with serial imaging. Historically, non-operative management was risky. Open surgery has risks, maybe 5–10% stroke death, plus cranial nerve injury risk, 12 to 20% transient. Early endo results seem promising, potentially lower nerve injury stroke rates in some series. The chapter also covers carotid blowout, mycotic aneurysm management in pediatric cases.
Okay, chapter 99 covers several uncommon cerebrovascular disorders. A quick tour.
Sure. Carotid body tumors, CBTs, usually benign paragangliomas at the bifurcation. Need careful resection due to cranial nerve risk, 130%. Shambling classification guides surgery. Pre-op embolization is debated.
What else?
Carotid sinus syndrome, CSS, hypersensitive baroreceptors causing syncope, especially in the elderly. Diagnosed with carotid sinus massage. Pacing often needed for the cardioinhibitory type. Fibromuscular dysplasia, FMD, non-atherosclerotic disease, often string of beads look. Treat blood pressure. Consider antiplatelets if symptomatic, intervene for aneurysms or significant stenosis causing symptoms.
Moyamoya.
Moyamoya disease, progressive blockage of intracranial carotid circle of Willis, with the collaterals forming, high stroke risk, ischemic and hemorrhagic, medical management for risk factors. Surgical revascularization, bypass, can help reduce stroke risk. Interestingly, antiplatelets are usually avoided if asymptomatic.
What about loops and kinks? Carotid tortuosity.
Often seen. Causality for symptoms debated. Medical therapy first. Surgery to straighten, publication elongation, only for highly selected symptomatic patients. Finally, intracranial stenosis Sampre's trial showed medical management, antiplatelet statins, BP control, is generally superior to stenting for symptomatic intracranial disease due to higher procedural risks with stenting.
Okay, last chapter for this section. Chapter 101, brachiocephalic artery disease. Surgical treatment, the great vessels off the arch.
Exactly. Innominate, subclavian, proximal common carotids. Covers dissection, usually medical management first. Aneurysms, surveillance for small asymptomatic ones might be okay now. Open repair is high risk. Endo is tricky, maybe bypass. And occlusive disease. Also mentions comoral diverticulum with aberrant right subclavian aneurysms repair if symptomatic or degenerating.
Surgical options for occlusive disease here, transthoracic.
Transthoracic approaches in endarterectomy or bypass are for more focal disease, usually needing a sternotomy. Endarterectomy has risks, 3–7% stroke, 5–7% mortality. Bypass from the ascending aorta is often preferred for extensive disease, using grafts. Requires careful technique, partial aortic clamping.
What about avoiding the sternotomy, cervical bypasses?
Yes, extrathoracic or cervical bypasses are common, especially for symptomatic disease or more proximal lesions. Things like carotid subclavian bypass, PTFE often use good patency. Axillary bypass, good for steel. Subclavian carotid transposition or carotid bypass, maybe retropharyngeal route. These generally have lower operative risk, 4%, and good 5-year patency, up to 90%. Table 101.2 summarizes results. The chapter also mentions variant anatomy and ultrasound signs.
Wow, that was a comprehensive tour through 15 chapters. We've covered a huge amount. So, boiling it all down for the vascular surgeon listening, what are the absolute key takeaways from this deep dive into Rutherford section 13?
I think the main thing is that this section, synthesized, really does function as that practical instruction manual. It grounds you in the epidemiology, the risk factors, the crucial role of optimal medical therapy.
Right, OMT is fundamental.
Absolutely.
Yeah.
Then it gives you the evidence and techniques for decision-making around intervention, CEA, CAS, TCIR, weighing the risks and benefits based on symptoms, anatomy, patient factors. And it covers the critical management of acute stroke with thrombectomy, plus these other important areas like aneurysms and less common disorders. It's about having that evidence-based framework from Rutherford's at your fingertips.
And where are the frontiers? The area is still evolving or debated?
Well, screening for asymptomatic carotid stenosis remains a big one. Who, when, how, especially with better medical therapy. The optimal approach for carotid intervention itself is constantly debated. CEA versus CAS versus TCR, which patients benefit most from which approach. The timing of intervention. And the role of endovascular therapy just keeps expanding, not just acute stroke, but maybe intracranial disease, aneurysms. The technology and evidence are always moving.
Definitely a dynamic field. So, a final provocative thought for our listeners to chew on, based on everything we've discussed from Rutherford's.
Considering how fast things are moving, both medical therapies getting better and endovascular tools getting more sophisticated, how different will our algorithms for managing cerebrovascular disease look in, say, 10 years? What new skills, what new knowledge, maybe what new collaborations will vascular surgeons need to really master to keep delivering the best possible care and improving outcomes in this incredibly important field? This section gives you the foundation, but the future is definitely going to keep us on our toes.